Sally Pipes is a Canadian. She owns up to that. And she was an economist and policy analyst in Canada for some time with the Fraser Institute, a free market institute in Canada. But for 21 years now, she has been head of the Pacific Research Institute in San Francisco, where she studies many aspects of policy, but especially health policy. And she's written a number of books on this subject, including more than one that focus on issues surrounding Obamacare or the Affordable Care Act. The most recent, is it the most recent? There's one forthcoming called Obamacare, The Cure for Obamacare. And one already in print is the Pipes Plan, the top 10 ways to dismantle and replace Obamacare. Good title, the top 10 ways. It might be featured on late night TV or something. It makes you wonder about the 11th way and whether it almost made the grade or what have you. But Sally is very knowledgeable not only about healthcare issues in the United States, but comparative policy issues in Canada and Europe and elsewhere. And we are very grateful to have her here to illuminate us on these vitally important issues. So please join me in welcoming Sally Pipes.
Well, thank you. And just so you don't think I'm so vain that I would title the book myself, The Pipes Plan, my publisher, Regnery Publishing, called it The Pipes Plan because they thought alliteration of the P was the way to go. So anyway, I have a few copies over here, and if you're interested after, please take one for free. Then we don't have to take them home back to California. So I wanted to thank Ralph Hancock for organizing this trip for Charles and myself. It's been terrific. And also at the John Adams Center, which helped to get this going. And Sam Lyman, who has been terrific, sort of doing all the details. So thank you all and thank you for coming today. The 2,700-page Patient Protection and Affordable Care Act was signed into law on March 23, 2010. It's just celebrated its 3rd birthday. But with the June 28th last year Supreme Court ruling that the Affordable Care Act was constitutional, looking at the individual mandate under Congress's power to tax, and of course the November 6th election when President Obama was reelected, it is, in my mind, unfortunate, but the Affordable Care Act is today the law of the land. But I'm going to talk to you about what can be done between now and 2016 and what I would like to see done to our healthcare system between 2016 and thereafter. 52% of Americans today still favor repeal of the Affordable Care Act, which is amazing to me that that number is still way up there, and yet you know, the election went the way it did. And of course, the Supreme Court decision on the individual mandate was a surprise to me, but we have to deal with what we have to deal with. Nancy Pelosi, the former speaker, who, of course, President Obama wants the Democrats to take the House back so that she can become the speaker again, she made this very important statement 11 days before the signing of the law. She said, "We must pass this bill so that we can find out what's in it." Think about that. Now, here we are, it's April 2013. I think that the American people between now and January 2014 are going to be absolutely surprised when they find out what's in it, because we have a lot of things happening between October and 2014. What I like to say is understanding healthcare is similar to unraveling an onion, many layers and many tearful moments. I understand Ralph is the cook in their house, so he'll get this. But the key goal for all Americans is affordable, accessible, quality care. And there are two visions of how to achieve this goal. One, which is the one that I support, relies on empowering doctors and patients. The other relies on increasing the power of the federal government in our healthcare system through increased mandates, taxes, subsidies, and controls on insurance companies. This was President Obama's goal. He really believed in what the late Senator Ted Kennedy did in the whole idea of Medicare for all. He really wants the government to take over the healthcare system, and said it many times before he was elected president. He said, if I were designing a healthcare system, I would design a single-payer healthcare system. Very few people realize we don't have a free market in healthcare in this country. 50% of healthcare in this country is in the hands of government through Medicare, Medicaid, CHIP, the Children's Program, and the Veterans Administration. So in the United States, and I heard this earlier today at a little luncheon talk, the United States spends almost 18% of its gross domestic product on healthcare, about $2.6 trillion a year, and it is the most expensive healthcare system in the world. This number will probably, even under the Affordable Care Act, go up to about 20% of GDP by 2020, according to Health Affairs that has done numbers. But, you know, when you look at what we spend, you often hear comparisons to other countries. For example, our spending at almost 18% of GDP was 5 percentage points higher than in any of the next 3 countries surveyed by the OECD, Netherlands, France, and Germany. But all of these countries are facing increasing cost problems with their health care. The United States is a very wealthy country, and as such, we demand the very best treatment that there is. But organizations like WHO, the World Health Organization, the OECD, the Institute of Medicine, the Commonwealth Fund, keep telling us that in the United States, other high-income countries outrank the U.S. on most measures of health. They conclude that the U.S. is among the wealthiest nations in the world, but it is far from the healthiest. So let's look at Canada in the beginning, the country where I come from. It's our neighbor to the north. Canada spends 11.4% of GDP on healthcare. Canada is one of the 3 countries in the world that has a true single-payer government-run healthcare, i.e. private healthcare in Canada is outlawed under the Canada Health Act. The government, therefore, sets a global budget. They determine what they feel they can spend on healthcare, and that is 11.4%. But the demand for healthcare in Canada is much greater than what the government is prepared to provide. And so Canadians face a long waiting list for care. According to the Fraser Institute last year, the average Canadian, from seeing a primary care doctor to getting treatment by a specialist, the wait 17.8 weeks. That is over 4 months. So if you look at the Canadian healthcare system, as an example, my own mother, who in June 2005 thought that she had colon cancer. So she went to her general practitioner, primary care doctor, who sort of felt around and said, well, I don't think you have colon cancer. But he'd had an x-ray taken. Well, I know none of you are in, medical doctors probably here, but you don't detect colon cancer with an x-ray. So her impatient Canadian daughter, now living in America, said, call back and say that you need a colonoscopy. And so my mom called back and said, my daughter says I have to have a colonoscopy, because Canadians are so nice they would never like to demand something like that. So the doctor said, well, unfortunately, because you're a senior, we cannot get you a colonoscopy. The waiting list for people, in their 50s and below is too long for people who have severe problems. So by November, my mom had lost 30 pounds, and she started to hemorrhage. And so we got her to the hospital in an ambulance, because that's the only way she could get into the emergency room. She spent 2 days in the emergency room, 2 days in the transit lounge, waiting for a bed in a ward. She got her bed in the ward, had her colonoscopy, and passed away 2 weeks later from metastasized colon cancer. Rationing health care is cheaper than providing care. Canada ranks 14th out of 25 OECD countries in MRI machines per capita, and 19th out of 26 countries in CT scanners. 40,000 Canadians every year seek treatment outside of Canada and in the US for treatment that they feel the waiting time is too long. Of course, politicians in Canada don't wait. Belinda Stronach, former Liberal MP, when she was diagnosed with breast cancer, did she say, well, I'll wait, 5 to 6 months for surgery? No. She picked up her stuff, went to UCLA, and had her breast cancer surgery and treatment, and paid for it out of pocket. Interestingly, though, Belinda Stronach was a person who didn't want to open the Canadian healthcare system up to any user fees or privatization. So people do have choices. The United States today is an escape valve for people not only in Canada, but for people in other countries. My friend, Dr. Brian Day, who is an orthopedic surgeon in Canada, runs a private clinic, which is illegal. He has 150 orthopods, and the British Columbia government is suing him because he shouldn't be able to do this. In June 2005, the Canadian Supreme Court ruled that for the province of Quebec, that the ban on private health insurance and private health care was illegal. Madam Chief Justice Beverly McLaughlin, not a conservative, said, Canada does have universal coverage. Everyone has their care card. Just like, remember Hillary? You're probably all too young to remember Hillary, back when Hillary Care was around. But Hillary would hold up that care card and say, we will all have security of health care. Well, Canadians have a care card. But as Madam Chief Justice Beverly McLaughlin said, access to a waiting list is not access to health care. And I did outline those waiting times. We constantly hear in the United States that groups such as WHO, OECD, Commonwealth Fund say that our healthcare system is poor because we have low life expectancy, high rates of infant mortality, and low cancer survival rates. So I want to spend a few minutes talking about those three things. WHO ranks the United States 37th out of 191 countries, behind Canada, Britain, France, and Morocco in terms of quality of health care. Now, if I were diagnosed with breast cancer, would I want to go to Morocco or to Cuba? Probably not. But what you need to know is that these countries that do these surveys, what they measure is not whether a healthcare system treats people well, but whether it treats people equally. And just remember what I said a minute ago about Madam Chief Justice Beverly McLaughlin's point. So let's look at life expectancy. Lower life expectancy for sure is less than ideal, but it's not a good measure of a nation's health care. Professor Stephen Wolfe, the lead author on the Institute of Medicine study, said, life expectancy and other noted health outcomes are determined by much more than health care. He added that much of our health disadvantage comes from factors outside the clinical system and outside of what doctors and hospitals can do. Life expectancy is influenced by variables such as lifestyle choices, homicides, and car accidents. On a per capita basis, the United States ranks #1 in terms of homicide deaths, car deaths, obesity, and obesity. According to the OECD, even when all of these variables are removed, the United States does rank #1 in terms of life expectancy. And authors in a recent article in Health Affairs reported that many of the documented inefficiencies in our healthcare system simply add to the cost of care. They don't harm patients. These inefficiencies include duplication, defensive medicine, things like that. Infant mortality is another one. The U.S. does have a higher rate of infant mortality than Canada and several other European countries. Hence, many say that these healthcare systems in these countries are better because of lower rates of infant mortality. But the reality is that the United States, with its superior neonatal healthcare facilities, has allowed high-risk babies high-risk and low-weight babies to survive. But it means that our infant mortality rate is higher because of this, because most of these babies do not survive. And European countries have different statistical methods of measuring a live birth. For example, a birth is not a live birth in most European countries unless it is a certain weight and a certain length. So, you have to compare apples with apples. The U.S. is one of only 8 countries that counts extremely premature babies as live births, even though they have a low chance of survival. While good prenatal care can influence rates, other factors do contribute: socioeconomic status, the background of the mothers, and adolescent pregnancies. For all birth categories before full term, 37+ weeks, the U.S. does rank #2 or #3 among 9 countries for which comparable data exist. Only Sweden and Norway rank higher than we do. So hence, in other countries, These at-risk babies do not survive. They do not qualify in terms of length or weight, and so they're not counted as live births. Cancer survival. Lancet Oncology, the British journal that measures cancer survival rates, has shown that the United States ranks #1 in 5-year cancer survival rates in 13 of the 16 most common cancers that are found. This is because the United States, we have good cancer screening, high cancer screening rates, we have early diagnosis, no wait times for treatment, and we do have access to effective treatments and the best drugs in the world. Let's look at breast cancer. EU survival rate 5 years out, 79%. The United States, 83.5%. Prostate cancer for men, EU survival 78% 5 years out. Britain, only 51%, but the United States, 92%. And I was one of Rudy Giuliani's 4 advisors on healthcare when he was trying to get the nomination, and he himself had prostate cancer and quoted these statistics that he was, doing incredibly well. So we have high rates of life expectancy when you take out those factors. We do have very good rates. We have low infant mortality rates because we have the best neonatal care in the world. There was a woman in Calgary, Alberta, who was expecting quadruplets. Can you believe that there wasn't a single neonatal unit in Calgary, in Edmonton, in Alberta, or any adjoining province that could take her to deliver her quads? This woman was airlifted to Great Falls, Montana, a city of 55,000, where her quads were successfully delivered. When she came back to Alberta, she said, my quads would not be alive if it weren't for America. I had the chance. And when the president says cities like Great Falls with 55,000 shouldn't have neonatal units, they shouldn't have, MRI centers, these are important because they do allow us to live longer and healthier lives. So let's look at our healthcare system. Recent polls show that 45% of doctors, since the passing of Obamacare, are seriously considering getting out of the practice of medicine. The Association of Medical Colleges has said by 2025, there will be a shortage of 130,000 doctors in this country. Half will be primary care and half will be general surgeons. Deloitte Touche did a major study showing that 73% of doctors are not excited about the future of healthcare under Obamacare. The Physicians Foundation did a survey of docs under 40. I can't remember when I was under 40, but they say that the Patient Protection Affordable Care Act will negatively impact their practice, and 57% are not optimistic about the future of medicine. So the other thing we have to think about is there are surveys that are now showing that the brightest students are considering not going into medicine. We want the best and the brightest to go into medicine because they will allow us to live longer and healthier lives. In my previous book, The Truth About Obamacare, which came out in 2010, I have about 18 pillars that I look at under Obamacare. But I know you all have things to do, and so you don't want to be around for listening to me talk for a couple of hours on 18 pillars. But there are a few things that I did want to talk about. The president had 2 main goals: universal coverage and bending that cost curve down. Remember I said 18% of GDP spent on health care. So on the issue of universal coverage, we have about 48 million Americans who are uninsured. But it doesn't mean they're uninsured from the day they're born till the day they die. Many of them are in transition from quitting or losing a job, going to another job. They're counted as uninsured, even if they're without health insurance for a week or more. But under the Obamacare, there is an expansion of Medicaid, which will begin January 1st, 2014. They're going to add about 12 million people to Medicaid, and about 18 million people will receive subsidies from the federal government to purchase insurance in these exchanges that will be set up. But when you look at the 48 million Americans who are uninsured, 14 million of them are people who are eligible today for Medicaid and CHIP and have not signed up. Now you may ask, why haven't they signed up? Well, the reason they haven't signed up is, 1, doctors are reimbursed 35 to 42% below what they get for treating a private patient if they treat someone on Medicaid. And so it's very hard to find a doctor. And that is why a lot of people who are Medicaid eligible would rather turn up at an emergency room and get what is expensive care. There are about another 17 million are kids who are between, I call them kids, between 18 and 31 who decide they're what I call the young invincibles, people like you. Nothing is going to happen to you, so why would you spend $400 to $500 a month on health care? There are only about 9 million Americans who are chronically ill without health insurance for 2 years or more, and those are the people that we want to take care of. But with expanding Medicaid and the subsidies, the CBO has said there will still be 30 million Americans uninsured by 2019. So we will not achieve universal coverage under the ACA. The second thing is on cost. The president wanted a health care bill that cost $900 billion over 10 years. The CBO said it cost $940 billion over 10 years, from 2010 to 2019. But interestingly, they just revised the number in February. They say it's already up to $1.3 trillion from 2013 to 2022. And I believe, and along with a number of other economists, that this healthcare law between 2014, when the cost drivers come in, the Medicaid expansion, the subsidies, the employer mandate, the individual mandate, all of these things, the cost will be about $2.7 trillion over that 10-year period. And remember, when Lyndon Johnson signed the bill that brought Medicare and Medicaid into being in 1965, cost $3 billion in the first year. They predicted it would cost $12 billion by 1990. Who can tell me what Medicare cost in 1990? $110 billion. So, 10 times what they estimated it would cost. And so I have myself and a number of others who read and analyze the Affordable Care Act, there is no way that this is going to cost even $1.3 trillion. It's going to be very, very expensive. And remember, during the debate, the president said over and over again, the average premium for the average family will go down by $2,500. But the CBO that was getting ready for the Blair House Summit, when Obama was trying to get more Democrats on board, they said, stop. The average premium, when we've looked at it, is going to go up by $2,100. And already today, the average premium is up by $3,000. Last year, the average family premium for people with employer-based coverage, $15,745. The IRS says the average premium for a family employer-based coverage this year, $20,000. So these are, the cost of healthcare is continuing to go up, not down. Some of the other pillars, the individual mandate, that was part of, as I said, of the Supreme Court decision. Starting next year, it is mandatory that everyone has health insurance. If you don't, you have to pay a fine or a tax to the government, $95 or 1% of income, whichever is greater. I can tell you that a lot of people, and particularly young people like you, you're going to pay that $95 fine and not purchase health insurance. So this is what is going to happen under the individual mandate. There are also, under the law, many excise taxes that are coming into being on insurance companies. Starting in 2011, there was an excise tax, a $28 billion levy on drug companies. This year, January, a new 2.3% tax on medical device companies went into being. This is going to have a major impact on employment in the medical device sector. Even liberals like Elizabeth Warren, the new senator from Massachusetts, would like to see this law repealed and replaced. And then starting next year, there's a new health insurance tax on insurance companies, $11.3 billion they're going to collect. All of these taxes, government doesn't pay taxes. We as people pay taxes, and we are going to face higher costs. And the impact on the pharmaceutical and biologic industry, medical devices, because of these new taxes, is going to really, I think, have a negative impact on research and development. All R&D, about 80% of R&D in these areas is done in the United States. It's not done in Canada, Britain, France. These countries have price controls, and there's no incentive for doing research and development. A big issue in the arena right now are these exchanges. And just yesterday, Kathleen Sebelius announced that instead of costing $2 billion for the grants that they were sending to the 17 states that are managing their own exchanges, that were going to cost $2 billion. We've already paid out $4.4 billion in grants. And they expected that all of the states would set up their own exchanges. Well, here we are. 17 states did, but 26 states are allowing the feds to set up their exchanges, and 6 states are doing what we call federal partnerships. So, and there was no funding in the law for subsidies to the states if they were in exchanges that were operated by the federal government. So today, Kathleen Sebelius was asking Congress for an extra $1.5 billion to provide funding so that subsidies could go to the exchanges for those that are federally operated. So I think it's going to be very interesting. October 1st is the deadline for states to open give open enrollment for their exchanges, and they have to be operational by January 1st, 2014. I will be very, very surprised. I'll eat my hat if the exchanges, all the exchanges are ready by January 1st, 2014. And people are going to be surprised. As I mentioned, a lot of young people are going to pay that fine. And so the people who are buying in the exchanges are going to be people who are sicker and people who are older. So that's going to push up the cost of insurance. And yet insurance companies under the law can only increase premiums by 10%. So there's going to be a lot of unfolding in this onion over the exchanges. Medicare Advantage, that is going to be cut by $202 billion starting in, it was originally supposed to happen this year, but they've pushed that out to 2017. Medicare, the program for our seniors, is going to be cut by $716 billion over 10 years in order to fund that Medicaid expansion. So, you know, the Medicare trustees have said Medicare will be bankrupt by 2024 at a cost of $1 trillion, which is double what Medicare costs today. There are 3 ways that the government is seeing as ways to cut the cost of Medicare. One is the ACOs, the Accountable Care Organizations, where doctors and hospitals will be rewarded or penalized for how much they spend on treating seniors. The second is IPAB, that's the Independent Payment Advisory Board, not the iPad that most of you probably have. IPAB will be another way where these 15-member board will make decisions about, you know, whether care is for Medicare patients is too expensive or not. And the third way is PCORI, the Patient-Centered Outcomes Research Institute. PCORI, which is up and running now, they say they cannot tell doctors and hospitals, you know, how much they can spend or whether a treatment is medically effective versus cost effective, like NICE in the UK. But what will happen is that doctors will start rationing care and reducing what care they give, because doctors are reimbursed about 20% below for treating Medicare patients from what they get from treating private patients. We already know that 1 in 3 Medicare eligibles is already having a hard time finding a doctor. So care will be rationed. In addition to the $716 billion cut, care will be rationed by ACOs, which are giant HMOs, PCORI, and the IPAB. Interestingly, no one has yet been appointed to IPAB, and it's supposed to be starting April 1st of this year. And I think it's because so many Democrats have been annoyed with CMS and HHS and the president over this organization, which is going to ration care. I know most of you aren't out in the workforce, but there are new Medicare tax increases. So people like myself, as of January 1st, individuals earning $200,000 a year or more, couples $250,000, we have to pay a 0.9% increase in our Medicare payroll tax, so that brings it up to 2.35%. And there's also a new Medicare tax on unearned income. So anyone with an income of $200,000 or $250,000 as a family will face this new 3.8% tax on unearned income. That's interest, dividends, cap gains, anything over the value of your house that doesn't fall under the amount you can write off. A lot of people are going to be incredibly surprised, because if you live maybe in Minneapolis or Mississippi, an income of $200,000 is a lot of money. But if you live in a major city like Los Angeles, New York, Chicago, San Francisco, an income of $200,000 is not a lot of money. Medicaid, the states, as I mentioned, are going to have to expand their Medicaid programs, And there's been a lot in the media lately because a lot of states said because under the Supreme Court decision, 7-12, the federal government could not force the states to expand their Medicaid programs. So even though Obama and Kathleen Sebelius thought everyone would want to expand their Medicaid program, for anyone earning under 138% of the federal poverty level, that's about $15,600. Well, a lot of states have said, we are not going to take that Medicaid money. Bobby Jindal in Louisiana, Rick Perry in Texas. But interestingly, a few Republican governors have taken it. Rick Scott, who was very much against the Affordable Care Act, the governor of Florida, he has now come out and said he's going to take the Medicaid money. And I thought, why is that? And I looked and I thought, he's up for re-election. And you know how politicians are. All they want to do is be re-elected so they can do more harm than good. So Arkansas and Ohio are looking at some interesting privatization of Medicaid plans for the new eligibles. But anyway, it's going to be an interesting thing. And as the Attorney General in Texas said, how can we be sure that all this money for this Medicaid expansion is actually going to last? And so, you know, states that decide to take the federal funds and expand, they may find that after a couple of years, the government can't afford to provide that money. My last pillar is the employer mandate. I mean, a lot of your young people, you probably work part-time. Any employer with 50 or more employees starting next January who does not offer health insurance or it's deemed unaffordable, they will have to pay a fine of $2,000 per employee to the federal government so that their employees can get insurance in these state-based exchanges. The first 30 employees are exempt. A full-time employee is one who works 30 hours a week. But what we're finding now is that a lot of people, companies in the service sector, Applebee's, Pizza Hut, a lot of these companies are saying, we cannot afford to provide this, pay $2,000 per employee or provide full health coverage. So we're going to reduce our workforce from people working 30 hours a week down to 25, 26 hours a week. So these people will be part-time. Another thing is that McKinsey predicted that of the 160 million Americans who have employer-based coverage, 1/3 of them are going to lose their health care. Deloitte Touche said about 30 million. And of course, the Congressional Budget Office said somewhere between 7 billion and 20 billion will lose their employer-based coverage, and their company employer will pay this $2,000 per employee fine. Remember what the President promised all of us. If you like your health insurance and you like your doctor, nothing will change. This is why I'm saying starting in January 2014, a lot of American people are going to wake up and say, I thought I could keep my doctor and I could keep the insurance plan that I had. Well, this is just going to be a real eye-opener for the American people. And I'm very disappointed that it wasn't a really big issue in the 2012 election. And I don't want to run down Governor Romney, who, you know, lost the election. But for me, it was really depressing that he would not come out in his debates with President Obama and say, I thought what I did in Massachusetts and signing the Romney Care legislation that we would achieve universal coverage and we would bend the cost curve down. 6 years later, that hasn't happened, and therefore, I don't want the Affordable Care Act for all of America. But unfortunately, for whatever reason, he didn't feel he could do that, and so the debate that was really active in 2010, and the House, the Republicans took a lot of House seats back, that did not happen, and a result is that we have President Obama back. Many economists, myself included, believe that if this law is not repealed and replaced, there will be a public insurance option, and it'll be priced cheaper than what insurance companies can offer in the exchanges. And you've already seen in the media, the premiums for insurance in the exchanges are already going to be way higher than people originally thought. But the demand for health care will be higher than people think, and ultimately, I think private insurers will be crowded out of the market, and we will be left in a single-payer Medicare for all system. However, there is some hope. I'm very optimistic about repeal of some parts of the law because the Republicans have the House. They don't have the Senate. They don't have the presidency. But a number of Democrats are becoming concerned about certain parts. So there's that. There's also defunding of the Medicaid expansion and the subsidy level. As I say, the subsidies kick in between 138 and 400% of the FPL, federal poverty level. That is about, for a family of 4, that is $94,000. Even in Massachusetts, it's only 300%. So, and then third are these court cases, which I'm a little bit optimistic about. So, on repeal, I would like to see the health insurance tax repealed, the medical device tax repealed. Even in the Senate budget talks a couple of weeks ago, the Senate voted to repeal the medical device tax by a pretty overwhelming majority, although it's not binding, but it still shows that a number of Democrats in Minnesota and in Massachusetts, Elizabeth Warren, the chap in Minnesota, Al Franken, these Democrats also support repeal because they know it is impacting job creation and jobs in their states. I would like to see IPAB repealed, and the Class Act, of course, was repealed under the fiscal cliff. But before that, Sebelius said they couldn't make the long-term care program even work. There have been a number of bills introduced into the House to repeal these various things that I'm talking about, so we will see where they'll go. Cantor and Boehner are going to introduce more bills to repeal the whole legislation, but of course the Senate probably won't vote for that, and definitely Mr. Obama will not sign legislation to veto the Health Care Act because it is his signature issue and accomplishment in his mind. So I think we could see some defunding as well of the Medicaid and changing the subsidies. On the court cases, Oklahoma Governor, Attorney General Scott Pruitt has brought a case which against the federal funding for the federally chartered exchanges because, as I said earlier, there was no funding in the law for those, so we'll see how that goes. In the Fourth Circuit Court of Appeals, the U.S. Supreme Court ordered the Fourth Court Circuit to reopen the Liberty University case, which will look at employer mandate, individual mandate, and the contraception mandate as to whether or not they are constitutional. There's a third case-specific legal. Because the mandate originated in the Senate for the individual mandate for the tax in the Senate, not in the House, they've got a case on that because, of course, tax bills are supposed to start in the House. There are 50 lawsuits that have been filed over the contraception mandate. So I don't know, I'm thinking that some of these cases may make it to the U.S. Supreme Court, and if they are overturned, this will be a real blow to Obamacare. But of course, my long-term goal is repeal and replace of the whole law. So what are some of the things that we can do? What should the long-term replacement agenda look like? So in my PIPES plan, I have that, and you can, as I say, take a copy. But I want to empower doctors and patients, not third parties, whether the third party is an insurance company or a government agency. We need to change the federal tax code because during World War II, when wage and price controls were in, employers couldn't increase wages for their employees, so they went to the IRS and they were able to get that if employer provided health insurance, then they would be able to write that off as a cost. And then employees, we also get our health insurance tax-free. But if you lose your job, go into the individual market, you have to now purchase your health insurance, if you can get it or afford it, with after-tax dollars. So I'd like to see that playing field leveled. And then when we get a competitive market in healthcare, then we can look at getting people with chronic conditions into the mainstream. I'd like the states to do medical malpractice reform. We spend in this country about $210 billion on defensive medicine. Texas did some really interesting things in capping non-economic damages and punitive damages. 16,000 docs have gone back into Texas, and it's been very, very successful. Insurance should be portable. Insurance shouldn't be owned by your company. It should be yours, and if you change jobs or move state or whatever, it should be yours. Medicare reform, we need to do premium support or vouchers. We need to raise the eligibility age from 65 because back in the beginning, that was how long we lived, but today we live to 79, and it puts tremendous pressure on the program, which, as I said, is going bankrupt. And we need to do means testing. And Obama did talk about means testing in his budget yesterday. So Medicaid reform, I would like to see that. Block granting Medicaid funds from the feds to the states. Let them decide decide on how they want to design their own plans. So, and last, I'd like to see health savings accounts, which are private accounts where you can put that money away every month into an account. It moves forward tax-free. You combine it with a high deductible plan for catastrophes, and that is a way to empower doctors and patients. Oh, and finally, let's get the states to reduce those state mandates that add 20 to 50% to the cost of care. As I said earlier, Ralph Hancock may not want a health care plan that has alcohol rehabilitation, but I may want it, and I should be able to get the kind of plan that suits my needs. So the question I ask is, who do you want to be in charge of your health care? An HMO bureaucrat, a government bureaucrat, or do you yourself want to be in charge of your health care? As Newfoundland Premier Danny Williams, when he was Premier of Newfoundland, was diagnosed with a major heart problem, and he was told that the procedure he needed was not available in Newfoundland, and that the waiting time in Montreal and Toronto was going to be too long for him with his condition. So what did Danny Williams do? He packed up, went to Mount Sinai Hospital in Miami. He paid for his heart surgery himself, came back to Newfoundland. The Canadian media, how could you possibly go to that evil United States? People die in the streets there, and pay for your health care. Danny Williams said, it's my heart, it's my health, it's my choice. Universal choice is the key to universal coverage. Under Obamacare, our taxes are going to go up $1 trillion. There's $1 more trillion for the subsidies. Care will be rationed, the deficit will be up, debt will be up. Where will the best doctors in our country go? Where will we go to get the best health care? I want to set up Liberty ships off the coast so that people, the best docs, can be there. Or, because if I'm having a heart attack, I can't get to Thailand, Singapore, or India. But I have a new idea, Indian reservations. Indian reservations are exempt from Obamacare. And I don't know about you, but you can go to California, near Palm Springs, Cabazon, it's an Indian reservation. You can gamble at the Agua Caliente gambling casino. You can buy all your designer clothes at the outlet mall. So why wouldn't you be able to go and see your doctor there, get your health care, and have a hospital too? So Americans are innovative. These are some of the things that I'm looking at. Like welfare reform, this is a long-term fight. If this law is not repealed and replaced, we are on the road to serfdom. There will be no off-ramp after 2017. As my dear friend P.J. O'Rourke says, if you think healthcare is expensive now, just wait until it's free. Thank you.
Thank you, Sally. You've given me to think about my priorities in insurance. It's true that alcohol rehabilitation might not be there. I thought about anger management. Oh, okay, good. But then I thought, really the best would be if I could get everyone I have to cope with to have anger management instead of me. I mean, that I think would be ideal. But we do have some time for question and answer. So what's your name, Miss? Casey?
I just have a mic. So if you could wait till the mic comes around and then state your name and what you're studying, that would be great. Thank you.
Okay, so raise your hand and Casey will bring you a mic.
Gordon Lindsay, Public Health. Last election, you had both candidates sign in that Intermountain Healthcare was a center of excellence. Right. And their costs are about 34% less than the national average. In your mind, what is the opinion, or what is your opinion of how Intermountain Healthcare does that?
Well, Intermountain Healthcare, Mayo, Cleveland, Geisinger are all coordinated care organizations which have all been very good at controlling costs. They're in the private sector. Now, when President Obama said over and over again, well, you know, we need to do accountable care organizations. Let's look at Mayo, Cleveland Clinic, Geisinger. These are models that we should follow. And they're terrific. Well, did any one of those organizations sign on as ACOs under Obamacare? No. They all wrote letters saying we could not possibly do what we do if we had to be part of an accountable care organization. So they are very effective, but they couldn't, they all wrote letters saying we can't do what we do if we had to be an ACO under Obamacare.
But how do they keep the costs so low?
Well, because they're efficient, they pay their doctors according to set fees, and they really they take full management of a person's illness who goes there. I mean, Milton Friedman went to Mayo Clinic for his heart surgery, and he had all of his testing, all of his surgery, all of his post-operative care, all there, rather than going to different places, which leads to many inefficiencies in the system.
Hi, my name is Clayton Schmokel. I'm studying political science. I wanted to ask, in your ideal world, do you think the government has, what is the appropriate role of government in healthcare, or any form of Medicaid or Medicare appropriate in your view?
Well, I think definitely, I mean, as I said, I thought the government should, I mean, one of the things the feds could have done was to increase the funding to these high-risk pools, 25 to 50 billion. The Republicans are on board with that too. I didn't mention this, I couldn't say everything, but on February 15th, under Obamacare, the feds put $5 billion in to beef up these high-risk pools, so anyone with a pre-existing condition who'd been uninsured for 5 months or more could purchase insurance in these high-risk pools. And it was supposed to go, they were supposed to be there until January 2014 when the exchanges came into being. Well, what happened was on February 15th, they were out of money, so almost a year before they were supposed to, so they'd been shut down. But I think if they had done what I thought, and a number of others, put more money into the high-risk pools, we wouldn't have to do all of Obamacare. I mean, it would have been a good solution until we get a properly functioning healthcare market. I do believe that there should be a safety net for people who are disadvantaged, who can't afford. I mean, there are a number of people on Medicare. Warren Buffett, you know, on Medicare, he doesn't need to be on Medicare. Medicare and Medicaid should be there for those people who truly need help. And, you know, even the president said we need to raise the eligibility age, but he didn't put it in his budget, but he did put in the means testing part. So, you know, the president gave 59 speeches before the law became law, and he was talking about fraud in Medicare, and he said there's about $500 billion worth of fraud in our Medicare program. Well, you know, why not work on getting rid of fraud, which is in a program run by the federal government? And, you know, the reason is because the feds don't have enough money to hire the number of people to find out who is fraudulent. Insurance companies don't have the kind of fraud that the government does, because both in Medicaid and Medicare. There was a dentist in New York who charged $1 million a year to Medicaid for doing dental procedures, which there was absolutely no way that, you know, that would be humanly possible. So, you know, I think there has to be a safety net for those people who really need it, but we have to get rid of fraud and abuse, and we shouldn't have these programs there for people who truly, you know, can take care of themselves. Yes.
So Jocelyn Chowan, International Relations. How likely is it that the Affordable Care Act will be repealed by the time that it's all coming together? Yeah,
well, Milton Friedman used to call me a Pollyanna, so maybe I'm overly optimistic. But if as I believe that the American people are going to be truly absolutely awestruck by what this means for the cost of health care, their ability to get insurance starting in 2014, losing their employer-based coverage, the election of 2014 will be important for the Republicans to keep the House and take back the Senate. There are a number of seats that are up that they could take. But the real issue will be who's going to be the president in 2016, and will that person be a man or a woman with a great spine who will really push repeal and replace of the law. Of course, the Republicans would have to take the House, keep the House, and take back the Senate. And then early in 2017, there could be legislation for repeal and replace. And of course, people on the left keep saying, well, there is no replacement agenda. Well, Ramesh Ponnuru at AEI and National Review, Yuval Levin at Ethics and Public Policy, myself, there are a number of replacement agendas out there. And Dr. Tom Coburn, Dr. Tom Price, was Senator and House member, they all have replacement agendas, Paul Ryan. But the people on the left keep saying there is no replacement agenda. There are replacement agendas. Nobody has signed on to exactly the same one, but many components of these replacement agendas are virtually the same, and they are there. But it's going to be a slog. But as I said, if 2017 it's not repealed and replaced, it's going to be really tough. And, you know, at lunch today, one of the chaps said, well, you know, Canada has government-run health care. We have these long waits, ration care, things I've talked about. My uncle, who died of non-Hodgkin's lymphoma in 1999, the drug in the U.S. that was available and is being successful in treatment of NHL is called Rituxan. My cousin, who's a doctor, went to the head of the Cancer Control Agency in Vancouver and said, well, what about Rituxan? And he said, I don't know anything about it. Got back 2 weeks later and said, well, it's not on the formulary in British Columbia, so you'll have to go to Seattle to get it. So, I mean, so this chap this morning at lunch today said, well, the Canadians love their healthcare system. Well, yes, if you poll all Canadians on the healthcare system, if you don't need the healthcare system for anything other than a minor sore throats, you know, little things, it's fine. But when Decima polls those people who need specialized care, and that's where that long wait is, the 17.8 weeks, there's tremendous dissatisfaction, and there's a lot of articles in the media about how upset people are with the Canadian healthcare system. The third point is that, you know, the government fully took over the healthcare system in 1974. I mean, you people weren't even alive in 1974. And if you don't know any different, you think, well, that's just the way it is. And the fourth point is Canadians are really nice people. They're not like myself. I'm an impatient American now, as my mom told me. But, you know, Canadians, if the doctor says, I'm sorry, you can't get a colonoscopy because you're too old, Canadians and Brits would say, well, thank you, I guess that's the way it is. But Americans aren't going to do that. They'll be hammering on the doctor's door saying, I demand that I have this. So those are some of the things that, but I'm very, very worried because, as Milton used to say to me, Sally, show me some government programs that have been discontinued. And I was saying to Ralph, there are only one or two, and one is the mohair subsidy. And so that's why Ralph's mohair sweaters are so expensive today. But anyway, it's a very worrying thing. But I am optimistic because I think the American people are impatient, are going to be upset. Well, thank you.